Thank you. So this is a study we did during COVID. And I have to say, it's the first time I've met some of my co-investigators is here today, so it was nice to meet them. So this was an educational grant that ACNAP received to look at the injectable medications, because what often happens is something is put on the market, and then nobody uses it, and they want to know why. So this was partly why we did this study. So I'm on the Horizon 2020 ERA Paths investigator. So the aim of this study was to look at what are the facilitators and the barriers for the use of injectable therapies with cardiovascular disease. So we wanted to look at both patients and healthcare professionals' viewpoints on this. Because of COVID, we couldn't do these face-to-face, so these were done by telephone and MS Teams. And ironically, we found that research sometimes is easier when you're in forced situations like this. So this was done in the UK, primarily in Leeds, and in 2 sites in Italy, in Rome and Milan in 2021. And then as it was a qualitative study, we undertook coding and thematic analysis. So it was quite a large sample for a thematic analysis. We had 56 patients who were interviewed, 30 in the UK. All of them were unestablished injectable medications. And the average age was 66, but they ranged from 41 to 82. And 60% were male. And in Italy, a similar pattern was 26. Their average age slightly lower to 63 and 80% male as well. And then in terms of the healthcare professionals, we interviewed 19 healthcare professionals and a different range. So not just nurses or pharmacists, because we know it's a multidisciplinary care is what we offer. So it's important to get everybody's perspective. So it was pharmacists, doctors, nurses, and a pharmacy technician. And in Rome and Milan, it was 12 physicians in this group, 6 nurses and 1 pharmacist. So in terms of, obviously, we limited time, so we broke down the presentation into themes. And we know that patients' behaviours and beliefs is definitely something that plays a role in whether they want to take medication or not. So they were concerned about their unmanaged hyperlipidemia. And as Abby in her talk said, there are patients who don't want to take cholesterol statins. So these are potentially the group that you say, okay, you need to actually be on injectable medication. And they are concerned about their health, especially if they've got familial hypercholesteremia, where they have had family members who are ill and have had cardiac events. They also know that this is for life. It's not just like a COVID vaccine. They have to change their behaviour because they want to avoid a cardiovascular event. So how do they incorporate that into their healthcare? And then deciding about starting the injectable therapy and their previous experience on statins. In terms of their knowledge and education, finding information. As we know, patients love going onto Facebook and telling us what they found. And we're going, that's not really what we call evidence-based. So it's making sure they have the right information and they are actually, making an informed decision. And also understanding the genetic component. So a lot of patients will say, why me initially, but then they've got to get used to the fact they have got a familial condition. And also what knowledge they have about their pre-existing cholesterol medications. In terms of their clinical skills and experiences, ironically, before COVID, we did a narrative review, and we knew that most people didn't like injections. However, how many billions of COVID vaccinations later, we know people actually, it's not as big a deal as it used to be. So the needle phobia is a lot less. But we do know that there needs to be a standardized approach for the clinical support for patients. And also, if a clinician advocates the drug, patients are more likely to say, okay, I'll take that drug. They also want to know about the side effects, like everything. Are there going to be any side effects? How are they going to be overcome? And then, very importantly, there is the organisational and governance issues. Trying to get at paperwork. Bureaucracy comes into everything, as we know. And also, during COVID, could they get the drug at home? Because obviously they couldn't come to hospital. And also then, how can they take their injectables while they're maintaining their lifestyle? And do they need remote monitoring? So it's fine to say to a patient, yeah, start taking this drug. But they go, well, what's my cholesterol? Has it gone down? Has it gone up? Has it stayed the same? They want to know that the drug is actually making a difference. So some of the quotes for the patients, it was interesting. I'm quite resigned to the fact that, yes, I have a high cholesterol, but what worries me is if it gets out of hand. I am worried about or anxious, as you say, if you have another TIA or I have a stroke or something. That was one patient. Another male patient said he was resigned and fed up to years of side effects, so glad to be offered an alternative therapy and the positive effects of lowering his cholesterol. He'd been on it for 3 months. 4 months on now, he's happy and he gets his blood test results. So, these drugs are effective, and this is good advertising for other patients and say I've had a positive response. So in terms of knowledge and education, one patient actually said he'd had a stroke. They explained that his LDL levels were a contributing factor. I think this patient might have had good health literacy if he's talking about LDL, but he knows that now won't happen again. I love this one from another patient. Well, it's all medical gobbledygook, really, which I didn't understand anyway. And then another patient said they thought they'd made a wise choice. Their results were scientific evidence. We love it when they say that. And it was the right choice for them. They're still fighting against their cholesterol with all the possible and imaginable effects. But since I am lucky enough to be better off than the healthy ones. The Italians are always more flowery in their language. It was great doing the translations with them. And then in terms of the skills and experience, the patient said, I'd like to have seen it, expected it. So again, that needle phobia, the media always do big pictures of needles. They're like, no, it's not like that. It's much different in terms of preparation. And so, yes, killed off most of their fears, went for an interview with a cardiologist, had a dialogue. It was good. I liked it. It gave me confidence. And so the patients, again, having that shared decision-making and a positive response from the doctor. So in terms of organisation and governance, there were, the patients were saying that the change, some of these medications now are going to be once a month, or could be even, there's talk of once a year, which will be quite amazing if that happens. And they also said this patient once a fortnight works well for them. I accepted because I knew that anyway I was monitored and I wasn't left alone to do the drug. And I think, again, that's maybe we prescribe, give the patients their tablets and say bye, and we don't expect to see them again. They want some follow-up. That was really came across. Just in terms of the healthcare professionals, in the interest of time, again, there was a few things that are existing facilitators. So clinical goals, people who'd used insulin were much more positive in their view. If the caregivers, so a family member was involved, they were much more motivated. Word of mouth always works for patients. The previous, as we mentioned, statin intolerance and having just one shot. And then in terms of other facilitators, if there was a home delivery service, so again, getting the drug to the patient easily, but we really do need to have more education tools and strategies, and also rapid tests. Patients don't want to know, your cholesterol's fine. They want to know the actual numbers, and that's really important. And that is a very quick overview of our study. Thank you.